Hello.
Good evening, everyone. Welcome to TNFOG Bodhana PG case discussion. Today's topic is previous LS, and I would like to welcome Dr. Ramani Devi ma'am and hand over the session to her.
Good evening, everybody. I'm happy to chair this session, Bodhana PG case discussion on behalf of Dr. Revati Janagiraman and Dr. Sampath Kumari. Since both of them have gone to UFOXI North Zone at Varanasi, I'll be taking over this. And today we have the topic of previous LSCS, which is very, very important. And that will be the case discussion will be from Kanyakumari Medical College. Dr. Sinitra and Dr. Deepika will be the presenters. And the internals will be Dr. Sundarani and Dr. Rashmi Ajit, who are the associate and assistant professors from Kanyakumari Government Medical College. And Dr. Rashmi is also the secretary of Nagarkoil OBGYN Society. And the externals, we have Dr. Dr. Sundaravani is again an internal. She is an associate professor from Kanyakumari and she has published many articles and research papers in national journals. And the externals will be Dr. Minnal Kodi and Dr. T.V. Chitra. Dr. T.V. Chitra, all of you know that she is a very good academician and professor and unit chief of the PS unit of Medical Sciences Coimbatore. And she is the past president of Kovai OBGYN Society, Scientific Committee Chair of UFOXI 2019, member of IUGA and ISUOG. And her special interest is urogynecology and high-risk pregnancy. She is honored by Teaching Excellence Award in 2015 by the institution. She is a postgraduate teacher and examiner from the past since 1998. Faculty in Institutional Medical Education Technology Cell. She has been an invited faculty in many national and international conferences and organizing secretary for many departmental conferences and had published many publications in both national and international level. Then Dr. Minal Kodi is senior popular obstetrician and gynecologist and founder of JG Multi-Speciality Hospital at Chengalpat. She's also a sonologist, histolaparoscopic surgeon, colposcopic specialist, and then she has special interest in infertility. Trained in clinical ART at EAT, Mumbai and Natkarni IVF unit, attended national and conference of OBG till date to update her knowledge. And then she was a master trainer in TNHSP and CD screening program. Received award from the collector of Vellore for best performance in family planning and participated in various national and international conferences. UG and PG teacher with a rich experience of 22 years. And then she is an examiner for many examinations and published papers in Indian journals. Member of IMA, ISAR, OXY, and FOXY member. With this, and Dr. Deepika, she is a final year student and a young budding gynecologist from Kanyakumari Medical College. And Dr. Sinitra is also a final year student from Kanyakumari Medical College. I think they will be presenting the cases. I feel previous LSCS is a very, very important topic because we know the incidence of cesarean section is on the increase. And subsequently, we are at least for the sake of litigation, many of us we don't want to try even a VBAC, even if the patient asks, and hence we are left behind with a lot of previous cesarean sections coming up. And I think not only the obstetric part of it, and also the previous cesarean section has got many impact on the subsequent gynecological problems, secondary infertility, NISH, and then AUB and incisional hernias, and so many other problems are there. So I think that discussions will give us an insight when to do the previous LSCS, repeats LSCS, and when we should have for a go back for a VBAC, and how to monitor VBAC cases, and then all the complications we can come across. And with this, I hand over the session to Sahiti, or the MO, who is the MOC?
We
I think
would
the
like
moderator,
to...
Reshmi, can take over.
Moderator?
Reshmi,
Minnal
please.
Kodi madam, you unmute. Minnal Kodi madam, unmute. Not audible. Unmute. Not unmute. Yes.
Hello, am I audible now?
Yes, you are audible now.
Okay. Hello to everyone. We shall now start with the much debatable topic, pregnancy following cesarean section. I request the PGs to present the case. We'll run through the case. Yes?
Ready, ma'am?
Yes.
Presenting a case of previous cesarean
Make
section.
it full screen, ma. Make it full screen. Slideshow.
Slideshare there. Yeah, correct. The button the.
Press that button. Okay.
Good evening, ma'am. Presenting a case of previous cesarean section. 27 years old, Mrs. X, wife of Mr. Y, from Periyavillai, who is a housewife, studied up to BSc, belonging to class 3 socioeconomic status, who is a gravida to para 1 live 1, previous lower segment cesarean section, whose LMP is 29 May 2022 and EDD is 6/3/2023, gestational age of 38 weeks and 5 days. She is a booked and immunized case at Vattavilai PHC, admitted for safe confinement.
Just stop here in 1 minute. See, you said previous LSCS, isn't it?
Yes, ma'am.
So we do not know whether it's previous lower segment or what it is. So you can just comment as previous cesarean section.
Yes, ma'am.
Because you have not done the cesarean, you do not know what. 99% it might be only a lower segment
Lower
cesarean
segment.
section. So instead of commenting, just previous cesarean.
Yes, a few corrections in this. You start with the patient's name, a patient's name or Mrs. X, rather than taking it as 27-year-old, number one.
Okay.
And second, you said LMP EDD with history of regular cycles before
Okay.
you comment on the gestational age. Okay.
Yes.
And then these two. And she is a gravida to booked and immunized gravida to para 1 live 1 with one living child following cesarean section.
Okay.
Delivered by LSCS. These three things you add up in your intro.
Okay.
Okay.
Yes,
Fine.
ma'am.
Okay. Now run through the case.
History of presenting illness, no history of lower abdominal pain, no history of bleeding PV, no history of draining PV. She able to perceive fetal movements well. Menstrual history, attained menarche at 13 years of age with regular cycle 5/30. LMP is 29/5/2022. Marital history, married since 3 years, is a non-consanguineous marriage. Past after obstetric history, spontaneous conception after 3 months of marriage, booked and immunized at Vattavilai PHC. Her antenatal period was uneventful. There was no history of gestational hypertension or GDM. It is a boy baby born by emergency lower segment cesarean section in the first stage of labor at 39 weeks of gestation, done at Kanyakumari Government Medical College under spinal anesthesia. Indication is breech in labor. Birth weight is 3.1 kg. No intraoperative complications. The baby was now 1 year old. It's alive and healthy.
Yes.
1 minute. Just
In
stop
this
here. No?
after-
Just go back to this. See, you said she was unborn. So, having known it's a breech presentation, why did they do an emergency lower segment cesarean section? If it's a breech, what will you do? Normally,
Normally, primary breech will go for elective cesarean section.
elective cesarean section.
Why?
Then why did the patient have an emergency cesarean section at 13 weeks? And if it's the first stage of labor, how will the patient tell you the cesarean section was done in the first stage of labor?
Patient had
How did she
pain
come? She must
abdomen.
explain all that in detail. Yeah.
She had
See?
pain. She had pain abdomen only for 3 hours, ma'am.
Okay.
And then she came from home, reached here within 3 hours, and
Okay. Your good name,
Yeah.
PG. Your good name?
I'm Dr. Sunitra.
Sumitra. And then what happened?
Sumitra, this case doesn't have any complaint. It is only a pure obstetric case, no comorbid conditions, isn't it?
Yes, ma'am.
Okay, then you will have to start with no complaints of, don't start with no complaints. You start it as the first, she's married since so many years, so it was a non-consanguineous marriage, whatever it is. The first conception was so many years back after her marriage, and so many months later after her marriage, whether she was booked and immunized as you said, and then whether she went into spontaneous labor, you can say at term. She went into spontaneous labor or she was induced. See, for a primary breach, nowadays everybody has a scan in their hand. So primary breach, I don't think anybody leaves her for an emergency cesarean section, isn't it?
13 weeks. Did the patient tell you it is a breach? How will you make it to the breach? Because what did the patient tell you in her own words?
குழந்தை உட்கார்ந்து இருந்தது அப்படின்னு சொன்னாங்க.
Okay, so that because sometimes they say thala thirumbala could even mean many people even for disclosure they will tell you the same thing. So you must be very careful in finding out whether it's a breach. And if it's a breach, was asked, was she diagnosed it as a breach in the ante period? And did they plan for an elective cesarean section? Why did she have an emergency cesarean section? Is what you must try to find out. Because primary breach, most often they will do a elective cesarean section. 39 weeks. Then why did they not do an elective cesarean section? Any reason for that?
Patient was advised to do.
Yeah.
Patient was a case in PHC, ma'am. She was advised to do elective cesarean section, but she didn't turn back to our college, ma'am.
Okay.
Okay. See, like being treated in a PHC, I don't think any VHN also keeps a breach in the PHC. She always brings the patient around the term 37, 38, 39 weeks to the particular medical college. I don't know how in this case it was missed. Of course, it is not part of our thing now. Now having a breach, what are the salient features you get from this breach? From the first pregnancy, salient points.
If she is allowed for normal vaginal delivery in upcoming pregnancies, the outcome will be good, ma'am.
No. What I am saying from the salient points from your presentation of the first pregnancy. She's a primary. She was a primary. Previous LSCS was done at term. Okay, as an emergency. The indication being breach. What was the weight of the baby? 3.1 kg. Okay. So 3.1 kg and a breach presentation. Only one delivery that was by LSCS, and now your second presentation has to go.
Sumitra.
Yes, ma'am.
See, you said no intraoperative complications. Is it important? Is it only intraoperative complications, or would you like to know something more about the? Are you going to tell anything more about the first pregnancy?
Post-operative complications also we have to mention.
Intraoperative.
It's important. Is the slide coming up?
Yes, ma'am.
Just move on to that slide now. Move on to that slide.
Move to the next slide. Smitra, move to the next slide.
Yes, ma'am.
Okay.
This is the next slide.
Yeah. Come on. Yes. Continue.
In the post-operative period, no history of blood transfusion, no history of fever, no history of foul-smelling vaginal discharge, no history of any wound infection. Catheter was removed on second post-operative day. The patient was discharged on fourth post-operative day, and suture removal was done on 7th POD. No history of any contraceptive usage after the first pregnancy.
Okay, just stop here, Sumitra. Now, post-operative period is very important. Like intraoperative and post-operative for a cesarean section is very important. Now, tell me why you asked about blood transfusion. What did you want to know?
Any history of anemia.
Okay, what else?
This can affect the scar integrity. And
okay,
anything else will be poor.
When else will they give a blood transfusion?
Postpartum
Hemorrhage. More than 1 liter.
When there is more blood loss.
Okay, but what are you interested in finding out? PPH, what type of PPH do you think? Which might affect the next pregnancy? Is it
traumatic PPH?
Traumatic isn't, because you would like to know, supposing, so if a hemoglobin is normal and then she had a blood transfusion, was there any extension? So in that the patient will not tell you whether there was an extension. But if she received blood transfusion, it may be because of PPH, because of atonicity, but also it might be because of wound extension. Okay. And the next history is very important. No history of fever, no history of foul-smelling discharge. What is why did you ask that? That's a good point that you found, that you brought it. Why? Why?
If any history of fever or foul-smelling vaginal discharge,
what does it indicate?
It indicates puerperal sepsis.
Very good. Yes.
This can also
I don't have
affect
the puerperal sepsis. So what? So what?
this also affects the wound
Integrity of the wound, ma'am.
So it's a reflex endomyometritis and wound infection, and the wound will not, the scar will not heal. With that point is very, very important. All the postgraduates must make it a routine to mention about the postoperative period, because you do not know what is integrity of the scar. So one way in which you can find out the integrity is to find out what is the type of incision, because patients will not tell you I had a low sequence section. You do not know whether it's a J-shaped incision, what type of incision it was. And the second one is this evidence of puerperal sepsis. So the second question, I mean, the second line, you said no history of fever. Fever could occur because of many reasons in the postoperative period, isn't it? Are you worried about all the fevers?
Not only this, the patient was taken up as an emergency. So that
Yes.
is number one. She had fever. If there is fever, then you will have to think
Ma'am,
whether the antibiotic coverage was given just before taking the patient for section emergency.
Now, what is the reason for fever in the postoperative period? You say any patient. What I'm asking is, are you concerned about fever? Fever could be because of many reasons, isn't it? Why? What
Yes,
are all the
ma'am.
various reasons for fever? Following cesarean section, what are the various reasons for fever?
Choreo membranes ruptured outside.
Okay, puerperal sepsis is the commonest. Okay, yes. What are the other reasons?
Chorioamnionitis, urinary tract infection,
Yeah, that is a commonest, isn't it? UTI, yeah. Then
wound infection.
wound infection.
oh, see, somebody saying breast abscess, thrombophlebitis. Thrombophlebitis is another thing that you must find out. Respiratory tract infection, anything could happen. This is what you must find out. So you're not worried about all those things. You're only worried about the infection which is going to affect the integrity. Okay. Now you said catheter removed on the second day. Why? When will you remove the catheter following a cesarean section routinely?
After 12 hours,
We can remove the catheter.
but in our
Most of it
hospital,
you remove within
Usually
12 hours,
what
isn't
when do
it?
you
yes, ma'am.
Yes.
Now, the fact that they remove the catheter the second day, what is the inference? When will you keep the catheter for a
Long period.
In case of any obstructed labor or
okay, very
any
good.
bladder injury during the intraoperative
So bladder
section.
injury will be removed on the second day.
No,
long
till
will you
Suspect,
keep 14.
ma'am, in case of severe adhesions, when we suspect bladder injury, we can keep the catheter for long
Sound
How
time.
many days? For how many days?
For 72
blood.
days.
Okay.
If you suspect
Routine
bladder
application.
injury, you have to keep it for a longer time. But suppose it's an adherent bladder, you found it difficult to push the bladder down, and you've done a cesarean in the second stage, then maybe you can keep the catheter for 2 days. Otherwise, normally they will not. They will remove within 12 hours. So the very fact that they remove the catheter for a longer time, you might think that maybe it was already in labor. That may be the reason. I'm not very sure. Okay.
Yes, ma'am.
But you should have asked why was the catheter kept for 2 days. Did you ask the patient? Why was the
Ma'am?
catheter kept for 2 days?
In our hospital, usually we are removing
Keeping it for
catheter
2
the
days,
second
48
day.
hours. What is ERAS? Very good. Tell me what
Ma'am,
is
we are
ERAS?
not audible.
What is
You are
ERAS?
Not able to hear you.
Me, yeah?
Yes, ma'am.
What is ERAS? ERAS.
Yes.
Enhanced recovery after surgery, ma'am.
So what is the recommendation? When will they remove the catheter?
12 hours
after.
Within 12 hours, they say you
Post-operative.
on the table you can remove the catheter. Then you kept it for 48 hours. That is very bad, isn't it? If you keep it for such a long time, what will happen? The patient is more prone to develop urinary tract infection. So now the recommendation is, the recommendation is you must try to for everybody. Okay. Now there's some
Yes, ma'am.
echoing somewhere.
Now your present obstetric history. Anything else you want to ask, Dr. Chitra?
Just have only one phone, no?
Yes, ma'am.
Okay.
Yes.
Yeah,
Ma'am?
Deepika, come on. Where you both, all of you have disappeared. Deepika and Sumitra.
Yes, ma'am.
Yeah. Sinitra. Okay. Yeah, come on. So just to complete this, can you tell me the components of ERAS? What are the things which is there? What are the principles in ERAS?
Preoperatively, The patient should be nil per oral for 6 hours for solid food and 2 hours for liquid food.
Yeah. Then?
Ma'am?
Yeah.
Preoperative antiemetics and antiemetics can be given. Then preoperative antibiotics 60 minutes before the skin incision should be given.
Okay. Okay.
Routine preoperative shaving of the parts is not needed. Then during the time of surgery, before anesthesia, spinal or the any spinal or general
just
anesthesia.
The broad principles.
Usually we do
broad
spinal.
Catheter can. Ma'am?
Yeah. So the basic points is you have to don't keep them starving for a very long time. You reduce because normally we keep overnight starving, so that is not there. So limit the starving. Okay. Early ambulation. Okay. And then removal of catheter and good analgesics.
Yes,
this is the way in which ERAS is a little different from your routine and get. There are many things component, but this is the basics that you must do. Early ambulation, less starving, early start of feeds. Within 2 to 4 hours, they say you can start it for solids itself. But we don't do it, isn't it? We give them liquid diet and then we give them a semi-solids. So they say you can start solids fast. Removal of catheter and good analgesics. Around the clock, you must give them a combination of analgesics, avoid morphine. Okay. Okay, fine. Continue.
Okay.
So because cesarean section, they will definitely be asked about ERAS.
Okay. Yes. Present obstetrical history. First trimester.
What was the inter-pregnancy interval?
It was 1 year, ma'am.
You have not said no. Second pregnancy you have started.
She wrote that, madam, the previous.
Baby was 1 year, I mentioned.
1 year old, she said.
Oh.
Now, see, the baby is now 1 year old. Now she's already 9 months pregnant, no?
Yes, ma'am.
Then how can it be, ma? Did she consider the next cycle itself? Baby is 1 year old. Now this particular person is 9 months pregnant, isn't it?
She told she had regular cycles after the delivery itself. After 2 months itself, she had a regular cycle, but she didn't fit. She has no period of lactation amenorrhea also.
Okay, okay. No. When did so you must find out? You see, 1 year is very short. It's unbelievable. When did she deliver? Which month did she deliver? When did she deliver? It might be 1 year, 3 months, because now she's 9 months old. The baby is 9. I mean, this pregnancy is 9 months. You're saying 1 year old. The first baby is 1 year old.
The
now
baby
she's 9
is
months pregnant.
1 year and 3 or 4 months, ma'am. The baby
so
is.
Okay, when was the last
it makes a lot of difference.
When was the last childbirth? Date or month?
That is very important, isn't it?
Last child.
Okay, you must. Okay, if not, I'm sure you've not asked, but you must find it very correctly. How many months back? Because what is the ideal interval which is required? Sunitra, what is the ideal interval which is required, Sunitra? 3 years is wrong. What is the minimum? Anybody? 1 year and 18 months at least should be there.
Yes,
18 months is
minimum
the minimum. Okay. So any pregnancy, the interval between both pregnancies should be at least 18 months. That is only ideal. Here, your particular patient, so if you say 1 year, it's 1 year and she's already 9 months, it is terrible. So must be very correct. Okay. Okay.
Usually it is 18 months. Usually inter-pregnancy interval should be 18 months, but following a previous cesarean section, if the next thing inter-pregnancy interval is 24, it is better. That is the book guidelines. ACOG.
Okay. Present obstetrical history, first trimester, spontaneous conception, pregnancy detected by urine pregnancy test at home at 2 months of amenorrhea, confirmed by dating scan at 8 weeks of gestation. There was no history of excessive vomiting, no history of fever with rashes, no history of radiation exposure, no history of bleeding per vaginum in the first trimester. Folic acid tablets taken regularly. She was immunized with 1 dose of injection tetanus. Number of antenatal visit in the first trimester was 2.
Okay, when was she booked? When was she booked to this hospital or wherever she wanted to go? Which was the first booking visit?
First booking visit was at 8 weeks of gestation, ma'am.
Okay,
After seeing UPT at home, she presented to the PHC at 2 months of gestation, and then she done dating scan.
Had you been the person there? At what investigations you would have done at that point?
Hemoglobin, then GCT, blood grouping, viral markers, HIV, HBs antigen,
urine albumin sugar deposit, random blood sugar,
Okay.
creatinine.
Why creatinine? Is it done routinely? Creatinine? That's not part of the routine investigation, isn't it? Then this person totally, you only said no history of hypertension, nothing, no GDM. Why do you want to do creatinine? You must be able to answer basic investigations. CBC, urine, blood grouping already, which is not that blood grouping, RS typing, fasting blood sugar or random blood sugar, thyroid test, and your serology, HIV, HPV, BDR. Okay.
Yes,
See,
yes.
why this dating scan is very important in this case. You said the dating scan done at 8 weeks. Why is
Yes,
it
ma'am.
very important?
First to assess the correct date.
Yes.
Then to see whether the gestational sac is implanted in the scar site or not.
No, that
Then
we cannot
any
make out. The
uterine
placenta you cannot make
anomalies
out
was
at
there
8
or
weeks.
not?
Okay. Hello. At the 8 weeks, you cannot make out the placenta. Okay. So 8 weeks, why it is important is because you want to date and whether it is corresponding to the period of
Not
amenorrhea.
placenta, gestational sac, whether it are or not.
Okay.
What else is important, Ma? When you do first trimester scan in a person with previous cesarean, how else is it important? One is to find out what is the gestation age. How else is important? Especially in this case of previous cesarean, how does the first trimester scan help you? Yes?
For elective cesarean section, pregnancy should complete 39 weeks, ma'am. For that, we need the confirmation of
Okay.
For that, you
gestational
want
age.
to.
No, what I'm
correspondence with
asking is, what I'm asking is, you want to know the exact gestation. That is agreed. My next question is, why is first trimester scan important in the case with previous cesarean? They already the answers come up with the chat box.
From the
Why?
audience.
What is important? What is increasing nowadays? What is on the rise?
Scar ectopic.
Scar pregnancy, isn't it?
Yes,
So you
ma'am.
must rule out a scar pregnancy. Ectopic. You want to rule out a scar pregnancy because that is increasing tremendously. So any patient with previous cesarean, it's very, very important to find out where the pregnancy is located. Is it a scar pregnancy? Okay. Yes, continue.
Second trimester quickening felt at 4th month of gestation.
Now, here, 1 minute. You've done
Yes,
a scan at first trimester. How many weeks have you done the scan? 10 weeks, 8 weeks.
8 weeks, ma'am.
After that, what will you do the scan?
NT
Buccal translucency scan.
You must do an NT scan, isn't it? Was it done or not for this patient?
No, ma'am. For this patient, it was not done. She has done only dating scan, ma'am.
Okay. So you must do it by regulation. Must do an NT scan. Okay. Yes.
Okay. Second trimester quickening felt.
When do you do that NT scan?
11 to 13 weeks.
11 to 13 plus 6 weeks.
13 plus 6.
Okay.
Second
What
trimester.
should be the CRL? What should be the CRL?
45 to 85 mm.
84. Okay. Okay. Is it now called the NT scan alone or anything else?
Double scan.
That are all biochemical markers.
Yes,
See, you are seeing in the first trimester scanning, you are also seeing the other things like this ductus venosus and tricuspid. Everything they are now seeing, and they have renamed the scanning as first trimester scanning.
Okay.
FPS. Okay.
Second trimester quickening felt at 4th month of gestation. Anomaly scan done at 20 weeks of gestation found to be normal. No history of bleeding per vaginum. No history of headache, blurring of vision, epigastric pain, or decreased urine output. No history of GDM. Iron and calcium tablet taken regularly. A number of AN visit in the second trimester is 4.
What else could have been can be done in this period?
Glucose challenge test.
Yes, you have to repeat the glucose OGCT. It's 75 grams OGCT between 24 and 28 weeks.
8 weeks.
Universal screening. Okay.
Yes.
Then
If the first trimester is normal, then you can repeat it 24 to 28 weeks.
that's
And if
what.
that is negative, then you can repeat that again at
32 weeks.
32.
Now, see the second trimester, you've done a scan for this particular person. Now, would you specifically look for something else in the scan?
Localization of placenta.
Second trimester.
And
Yes.
what else? What else? Yes, placenta, what else? Localization of placenta, and what else?
What else? Wherever you want to switch on the Dopplers.
What else will you do? That's very important now. Oh, yeah, very good.
That uterine artery
Sounds
notch.
very- No, what is it? Yes, yes, good. Yeah, sounds very correct. What is it?
Placenta accretus.
It has come from the chat box.
What is it? See, what are you worried in the case placenta previa? I've already told
Placenta
you.
accreta syndrome.
Placenta accreta syndrome is you must two things you must find out. Whenever you have a previous cesarean, you've done
Doppler
a
for
scan, you
vascularity.
must find out where the placenta is located. Is it a placenta previa? Because more chances of them having a placenta previa. And secondly, you must find out, is it a placenta accreta syndrome? Okay, so these two things must specifically complications of previous cesarean, the occurrence of a PAS,
Placenta previa
syndrome. So that should be done. And if you have done it in the second trimester, there is something that you can counsel the patient and do the necessary steps. There's no point in deciding, looking for it in the third trimester. So it's very, very important. Okay, don't forget it. Yes. Yes, continue.
Third trimester, she able to perceive fetal movements well. No history of gestational hypertension or GDM. No history of any abdominal pain, bleeding PV or draining per vaginum. Iron and calcium tablets taken regularly. A number of AN visit in third trimester is 3. Past history, no history of diabetes mellitus, hypertension, tuberculosis, bronchial asthma, epilepsy, thyroid disease, and heart disease. No history of previous blood transfusion. No history of any drug allergies. No history of other abdominal or pelvic surgeries. Personal history, mixed diet. She has normal sleep and appetite, normal bowel and bladder habits. No history of smoking or alcohol intake. No history of betel nut or tobacco chewing. Family history, no history of hypertension or diabetes in family, no history of any congenital anomalies, and no history of multiple pregnancies. General examination, patient is moderately built and nourished, no pale or no pedal edema. Height is 155 centimeter, pre-pregnancy weight is 55 kilogram, present weight is 66.5 kilogram, and BMI is 22.08.
Are you happy with the BMI?
Yes, ma'am.
Why?
It is within the normal range.
So what? Okay. Now you're dealing with the case of previous cesarean. How is the BMI going to impact your management?
In a pregnant woman with normal BMI,
I'm telling you about this case. You're talking about this case. So come to this discussion. Because the BMI is only low, you can choose the candidate for VBAC. The answers are coming. Isn't it? Suppose the BMI is high, then the VBAC becomes less. Okay, that is one. There are many factors for a VBAC score. One factor is a BMI. Okay.
Yes.
Yes, continue. Because you must consider your case. Your main thing would be, so you're dealing with the previous cesarean. I'm sure you would know that you would be a question whether you're going to give her a vaginal delivery or whether you're going to take her up for a cesarean section. So one favorable factor is the fact that she's having a low
normal
BMI. Yes.
Temperature is 98.4 degree Fahrenheit. Blood pressure is 110/70 millimeter of mercury, measured in right arm in sitting position. Pulse rate is 86 per minute, regular in rhythm and normal volume. Respiratory rate is 16 per minute. Breast, spine, and thyroid are normal. Gait is normal. Systemic examination. Cardiovascular system S1, S2 is present. No murmur. Respiratory system, normal vesicular breath sounds plus no added sounds. Obstetric examination, inspection, Patient in supine position with knees semi-flexed, abdomen longitudinally distended, flanks appears full, umbilicus in midline flushed with the surface, linea nigra present, stria gravidarum present. Suprapubic transverse scar present about 12 centimeter in length, appears healthy, healed by primary intention. No suprapubic bulge seen, no puckering, no hypertrophy or keloid over the scar. Hernial orifices are free.
What are the reasons why you can have a suprapubic bulge?
In case of any
In labor,
if the patient
labor?
present with labor,
uterine
in
rupture.
Labor is the suprapubic bulge, you will think of a
uterine rupture.
okay,
Before
you
that,
think of a
in-
scar disease or uterine rupture. What are the
Rupture.
other reasons when you see a suprapubic bulge?
Placental,
Hmm?
placental separation. Bladder, full
Placental
bladder.
Full bladder.
Full
Full
bladder.
bladder, isn't it?
Full
That's
bladder.
two things. So whenever in labor, if you see a suprapubic bulge, it doesn't mean always it is a scar dehiscence. You must think is it a bladder. So always empty the bladder and then only you have to rule out. Okay. Yes. Continue.
Palpation, symphysia fundal height is 30. Fundal height corresponds to 32 weeks with flanks full. Fundal grip, broad, soft, irregular, non-palatable mass present, suggestive of breach. Umbilical grip, uniform curved resistance present at the left side, suggestive of spine. Multiple irregular nodules present at the right side, suggestive of limb buds. First pelvic grip, hard, round, independently palatable mass present, suggestive of head is mobile. Second pelvic grip, mobile head with fetus in flexed attitude. On palpation, a clinically adequate liquor was present, no suprapubic tenderness, and estimated fetal weight is 3.5 kg.
Okay. See,
Auscultation.
Auscultation, fetal heart sound heard at the left spino-umbilical line. Heart rate is 150 per minute.
just because she had a previous pregnancy sometime back only, was there any sinus discharge from the previous cesarean scar?
No, ma'am, no sinus discharge.
Nothing, nothing. How to
Yes.
make out the scar tenderness? How to make it? Usually, what is the incidence of cesarean section with in the lower segment cesarean section? What is the incidence of rupture or scar dehiscence? When does it happen? And with the classical section, when does the rupture happen?
Incidence of previous lower segment cesarean section, the scar rupture is about 0.5 to 0.9%. In a classical,
during labor,
it occurs during the process of labor. In classical cesarean section, the rate is 4 to 9%, and it can occur before the labor starts.
Is it before the labor starts?
Even the 4 to 5 weeks before the.
Because 34 weeks, around 34 weeks, that is the maximum stretch that happens in the uterus. At that time only the classical cesarean section will give way. Okay.
Okay.
And then how to palpate for the scar tenderness? If suppose she is 38 weeks or so, how to palpate?
After voiding the bladder, by palpating,
First is how to describe the
patient's attention, and palpation using the palmar aspect of the hand in the hypogastric region from the right iliac fossa to the left iliac fossa. Pressure is applied over the hypogastric region.
Why you want to go from the right iliac fossa?
Hypogastric
we are
to go all the from right iliac fossa to left iliac fossa. That much will be so many centimeters. It will be at least 25-30 centimeters. You only over the scar only, from the right side to the left side of the scar. Okay, you don't have to go from this end to that end.
Yes. And palpate also just above the symphysis pubis. At that time, when you are engaging the patient in something, when you are palpating the patient, what will she do? She will wince with pain. Suppose she has got tenderness, she will wince with pain. Okay.
Now, this particular person, supposing she had a midline scar. Okay. First time cesarean was done by midline abdominal incision. Okay, now your palpation, I'm sure it will vary. How will you look for scar tenderness in this case?
Again, the same way, transversely we have to elicit the scar
because
tenderness. We are eliciting only the uterine
scar. So, irrespective of how the scar, abdominal scar is, always scar tenderness should be seen only in the lower uterine segment. It's only the suprapubic tenderness it is not over the midline. Okay, don't make that mistake. Okay. Now you said this is a case with the previous is done for a breech presentation, isn't it?
Yes.
Now I'm sure all of you all in Government Hospital have started writing what is the indication for a breech and what is the Robson classification. Can you tell me what the Robson classification was? The first indication.
It is 6, ma'am. For nulliparous breach, the Robson score is 6.
Very good. Yes. So you must be up to date with that. Okay, good. Okay. Yeah. Good. So now, so she's 38 weeks, 5 days with single life fetus in longitudinal life, cephalic presentation, not in labor, admitted for safe confinement. So now what is the decision you have to decide? How are you going to go move on from here? Suppose you've seen her in the anti-OPD. She's 38 weeks and 5 days. Now she's going to ask you, what is the most important question that she's going to ask you?
When will
What
How will you counsel the patient? How will you counsel the patient at 38 weeks with a non-recurrent indication? Now with the cephalic presentation, baby weight is 3.5 kgs, as you said. Was any other method of confirming whether it could be 3.5 or less than that? Any other method other than your clinical palpation?
Ultrasound machine.
Ultrasound. So ultrasound also, and also the amount of everything. Okay. So with that, now you are going to counsel the patient in the late pregnancy, later weeks of pregnancy. What is the counseling you are going to give and how you are going to proceed?
Before that, no, can you just tell me, is there any way in which you'll be able to predict whether this particular person will, only if you know, whether she can deliver vaginally, you're going to tell her, come on, let us wait for the vaginal delivery. So is there any score by which you can predict?
Yes, the Weston score and Weston score is
what is the score? Yeah, tell me the components of the score.
It depends on the previous history of normal vaginal delivery. Then Bishop's score in the present pregnancy.
Spontaneous onset of labor and the cervical dilatation at the onset of labor. If it is more than 4,
and also the indications
indication for previous
LSCS performed.
Okay, so the favorable factors would be what is the Bishop scoring, whether the patient had a previous vaginal delivery, and then what is the age of the patient, what is the BMI of the patient, and what was the
indication.
What is the indication for the previous step? So here in this particular person, you tell me what would be the score, what are the favorable factors for you to say that there are chances that this particular person can deliver vaginal. So you must,
it is a non-recurrent.
You must know.
First pregnancy, she has LSCS for breech, ma'am. So it is a favorable.
It's a favorable of all the presentations, of all the indications. They say an indication for a mal presentation is said to be is said to have the highest chance of having a vaginal delivery when compared to a cesarean done for a fetal distress or a dystocia. So she's a mal presentation, that is very favorable. Okay, and then what else is favorable?
Singleton pregnancy in a cephalic presentation.
Okay, and she's also 38 plus 5 weeks in term gestation.
Okay.
Then normal BMI is normal.
So the VBAC
also age.
And you've not, the only thing you've not done a vaginal examination. In this case, should you do a vaginal examination now?
When will you do the vaginal examination? When will you do the vaginal examination? Or what counseling? During counseling, what are all the things to be taken into account? Whether the patient can be, she may want a repeat section, and she may also insist on a trial of labor after cesarean section. So what is that you are going to counsel the patient?
We should explain her about both the risks and benefits of elective cesarean section and also the VBAC.
Okay, for TOLAC, don't say VBAC. It is vaginal growth after cesarean section is the outcome of TOLAC.
Yes, ma'am.
Okay, so during for TOLAC, if you are convincing the patient or you are explaining that the patient can have a TOLAC because you want to reduce the incidence of repeat cesarean section and other things. Okay, the incidence increasing trend. So if you want to suggest that, what are all the 4 points for making her to deliver? What will you tell for TOLAC?
Less hospital stay,
less blood loss,
less blood loss.
No, not like that. See, what madam is asking is how will you counsel her, saying that you can in your patient, you can give her a vaginal delivery. You must tell her this is favorable in your case, so you can give a vaginal delivery. So like that, what?
Being a normal average BMI women with singleton pregnancy in cephalic presentation, For a non-recurring indication,
age is also 27 years.
So the only thing that you missed out is why you did not do vaginal examination.
When will you do a vaginal exam?
Her LCB is only 1 year and 3 months, man, and also
okay, that is the
she's
point
having a
again. But
morbid-
you should have done a vaginal examination, isn't it? That is not.
Why do you want to have a? Suppose because it's a Catholic presentation. So if suppose you want to, if suppose she lands up in an emergency like previous time, and you have to give her a vaginal delivery, you should know the, adequacy of the pelvis, adequacy of the pelvis at all levels, and also the Bishop scoring. If she is admitted earlier, when will you admit this patient?
She is 38.
Okay, for counseling, come on, we've not finished the counseling part. So, in your part, what are you going to do? Are you going to give her a vaginal delivery, or are you planning for a cesarean section?
Cesarean section, being LCB is only 1 year, so we are planning for elective cesarean section for this patient.
Still, you don't want to do
no, but the only factor in this case is LCB is 1 year. Is that the most important thing? There are so many things. She's had a cesarean section for a non-recurring indication, is a single baby. I'm saying, suppose the patient says, I want a vaginal delivery. Is it absolutely complicated just because she's conceived immediately and LCB is 1 year? The chances of rupture might be more. But that
even she
indication for a vaginal delivery. Nowhere they said just because a cesarean is done 1 year ago, you have to do a repeat cesarean. The chances of prolapse failure is less, maybe, but it doesn't. It's not an indication for repeat cesarean section. Understood? And in this chances of prolapse being successful may be less. Okay, so you must tell us the points for your class. Then why the discussion?
Yes,
you must tell us.
Now see,
everything is favorable for your
is
patient.
now 38 plus 5 weeks, and
Yes,
you want to take her up for cesarean section. Any other thing you want to know about the scar? Other than your clinical examination, all that, you will have to see the scar integrity and the thickness of the myometrium.
Yes, ma'am.
Okay, when will you do it? When will the ultrasound tell you at what periods you will do the ultrasound? And what should be the findings? What are all the findings you will get?
Usually the integrity of scar thickness should be measured preconceptionally or during the first antenatal visit we have to.
No. See, at
34 to 36 weeks.
Yes, first ultrasound is done at 34 weeks. The repeat ultrasound?
36.
You will do it in 38 weeks. And what are all the findings you will arrive?
First, the thickness of the scar thickness should be
more than 2.5 mm.
Then we should look 2 to 3.
What should be the how to measure in ultrasound the thickness of the scar? Sometimes
between the urine in the bladder and the amniotic fluid, ma'am.
Yes, between these two. And what should be the thickness?
2 to 3.5 is the normal range.
So less than 3. We always think, and one is thickness of the scar. Second one.
Any wedging or loss of
wedge defect, any wedge defect is there.
Wedge defect or the loss of integrity of the scar, the moth-eaten appearance. You get it? And which is a very best method to do it?
MRI, ma'am.
MRI. Okay, 3D ultrasound can replace MRI, which is costly. And somebody has put it in the chat box, the location of the placenta again at that time.
Yes, ma'am.
Okay.
Not in the placenta location, we also look for PAS because sometimes you might have missed. For how will you make out whether the features for PAS? Tell the important features for PAS.
Loss of clear zone. Retroplacentally.
Retroplacentally. Okay. Yes. Then
myometrial thinning.
Less than 10 mm.
Okay.
Then
abnormal
feeding vessels.
In
abnormal feeding vessels
at the bladder
and the uterine serosal
Uterine
surface.
serosa. Okay, and then
So,
Loss of clear
lacunae.
Lacunae formation.
placenta, lacunae, and then you might be able to see the placental bulge into the bulge in the lower uterine segment. So bulge, increased vascularity, thinning, and loss of sonolucent area plus placental lacunae. All these features will tell you it is a morbidly adherent placenta. So before a cesarean section, it's important to see for all those things, where's the placenta localization, and look for PAS. Okay. So now, so you, according to you, want to plan for repeat elective cesarean section in this particular case, isn't it?
Yes,
Okay.
ma'am.
So
Suppose
how
the
many
patient
people
doesn't
can-
want. Suppose the patient doesn't want. What are you going to tell? She wants VBAC or TOLAC.
We will explain about the risk of scar rupture because our LCD
Now you
is
have seen the scar. The thickness of the scar is more than 3, and but other than that, you don't see any smooth, no bulging of the placenta into the bladder or something, no thinning of the myometrium. When all these things, with all these things, you have done a per vaginal examination to rule out a CPD. In this case, you said 3.5 kg. Suppose it is 3 kg or 2.8.
Ma'am,
You
I'll
will
allow for
have to-
VBAC, ma'am. Being a tertiary, TOLAC, being a tertiary institute, we can allow her for TOLAC, ma'am.
Yes. Okay.
With 24 hours obstetrician and anesthetic service and 24 hours blood bank service, we can allow for TOLAC.
Yes. You can allow.
What's the difference between TOLAC and VBAC?
TOLAC is just a trial of labor.
It is irrespective of the outcome of the delivery, ma'am.
If the
But if it goes for a vaginal delivery, then it is vaginal birth after cesarean.
Successful vaginal delivery is VBAC. Okay.
Very good.
Then
So now you allow this patient for vaginal delivery because she insisted on vaginal delivery.
now the adequacy of the patient is other than the I mean adequacy of the pelvis. What else you would like to see?
Bishop's score.
At 38 weeks. Or suppose the patient comes with spontaneous labor, you will admit the patient at 38 weeks.
Yes, ma'am.
Okay. And other than your adequacy testing for your CPD, what else you will assess at the time of vaginal examination?
Bishop's score, we will see, ma'am.
Okay. So Bishop's score of assessment. Favorability of the cervix has to be measured. Okay. You will keep a record. Everything has to be documented. That is number one. The second thing is what you are planning has to be known to your team. And also the program has to be written and documented as a written statement. Okay. Now you have done everything. Now it is 39 weeks crossed. Patient is going into spontaneous labor and not going into spontaneous labor. In these two conditions, how are you going to manage the patient?
If she is going for spontaneous labor, means the successful outcome is high, ma'am.
Okay.
In case of induction,
in which patient the successful thing is going to happen? I said spontaneous labor at
labor,
39
ma'am.
weeks. Spontaneous
labor.
Suppose it is 40 weeks and the patient is not landing up in spontaneous labor, what will you do?
Induction of labor can be done, ma'am, but mesoprostol is definitely contraindicated in TOLAC.
Induction of labor is, you said induction of labor. What is the best method to give induction?
Amniotomy, mechanical methods can be used, ma'am. Sweeping and
When will do amniotomy? Well, amniotomy is the method.
No,
that is an early
it is only
labor.
after the active stage.
Only after the services become favorable. So don't
Becomes
say, once you do an amniotomy, you're committed. So always amniotomy must be done as the last resort. Okay, so here you will only go for a mechanical
methods you can do.
What mechanical method?
Foley induction can be done.
Foley induction. Suppose the thing is less than, your scoring is less than 6 and you want to induce, you don't want to induce by Foley's. First preference go to Foley's. Can you use PG E1?
E1 is definitely contraindicated.
Contraindicated. E2?
Can be used.
How many times E2 can be used in a normal primate and how many times it can be used in a person with previous cesarean section?
Maximum
In a
3 doses.
normal
can be
priming,
used.
3 times it can be
Yes.
used.
Yes, previous section.
One.
Yes, only once. But this should be with the careful intrapartum monitoring. How are you going to?
What are the chances of rupture? How will you tell her? What all will you tell her? And in case of emergency, what all will you tell her? It's very important to get a consent, because if something happens, then she's going to be a catastrophic problem. So unless you tell us, so what all will come and tell me? What is the chance of rupture? What is the chance of vaginal delivery?
It's a 60 to 70% successful outcome, ma'am.
Yeah, so you must tell her there's only 60 to 70% chance that you're going to tell your vaginal. Yes, good. Next, second number 2.
If there is failure of TOLAC, then we will proceed with emergency cesarean section. That should be explained to the patient.
And
there is also
why
a
is that
chance.
important? Why is that important? Why is that important? That statement.
Emergency cesarean section can have
ends up in a cesarean section, those patients, the morbidity and mortality is very, very high. So you have to tell the patients very carefully. In case you end up in a cesarean section, then the risk for both you and the mother becomes high. That should be explained very carefully. Okay, then.
In case of ruptured uterus,
She's not a normal patient. So this patient, she is taken as a high risk, and so electronic fetal monitoring. Okay, continuous electronic fetal monitoring is a must in this case. Other than that, you have to check the vitals of the patient.
Yes.
How often you will check the vitals of the patient?
Blood pressure and pulse rate should be checked every 30 minutes, and fetal heart rate should be continuous electronic fetal monitoring. Patient should be in nil per oral with IV fluids can be given.
Blood should be cross-matched.
For cross-matching should be taken.
Anesthesia team should be informed priorly that the women is allowed for TOLAC. And if possible, one-to-one care.
Okay, yes, continue.
If possible, one-to-one care could be, can be given to the mother.
It has to be given.
Yes.
You can't just leave the patient and go. Okay, it has to be given. And then who all will be informed that the patient is on TOLAC?
Anesthesia and senior obstetrician,
theatre staff,
pediatrician,
and
blood bank facility.
And anesthetic blood bank facility.
Okay, what are the signs of scar rupture? When you
non-reassuring fetal heart is the first sign, ma'am.
Okay.
What will happen to the fetal heart? You said non-reassuring fetal heart. What is that?
Variable deceleration followed by
rate deceleration and then bradycardia.
Okay. Then
maternal tachycardia, bleeding per vagina, excessive bleeding per vaginum, hematuria can occur.
Okay.
Then in case of scar rupture, sudden
cessation of
pain.
Yes. What is it? What else?
Cessation of pain.
The loss of station in the cervical findings.
Easily palpable.
If you do a PV, the head will recede. Okay.
Easily palpable fetal parts.
Through the abdomen.
If you feel the fetal parts very easily, what does it mean?
Ma'am?
If you feel the fetal parts very easily, what does it mean?
Scar rupture.
Rupture, isn't it? What is the difference between a scar rupture and scar dehiscence?
The visceral peritoneum is intact. Only the visceral peritoneum is intact. It is scar dehiscence, ma'am. In complete uterine rupture, all the layers are lost.
No. What happens with scar dehiscence? What happens with the partial rupture? What happens with complete rupture?
Scar dehiscence may not need. It will heal on its own, ma'am. It doesn't need any lab.
At that time, when so many times we are doing cesarean section, we are taking the patient as doubtful scar integrity, and we find that it is scar dehiscence. How do you commit that it is scar dehiscence?
Serosal layer is intact.
Visceral peritoneum, if it is intact, then it is scar
No,
dehiscence.
the amniotic membrane will be intact in a dehiscence. In a partial rupture, the visceral peritoneum will be intact. You understand? This will be at the under aspect and this will be at the upper aspect. Visceral peritoneum, once it is intact, the fetal membrane is lost, the amniotic membrane is lost, and the scar is lost, but the visceral membrane is intact. It is partial
Partial
rupture.
rupture.
If it is totally given away, it is a complete rupture. Where does the rupture occur or dehiscence occur commonly? Which part? Which part of the
Over the scar site. All the scars.
okay, over the scar rent is happening. Where? At which part? It is mostly from the left end because the uterus is dextro-rotated and also the pressure is acting centrally. Okay, so the site of scar rupture will be over the left end. Scar dehiscence you will notice at the left side of the scar. Okay, and then
Your patient is fine. She's getting spontaneous contractions, and then you're monitoring her
CDT
temperature is normal. She's progressing in labor well. So what will you do with the first stage? Suppose if contractions are only 3 contractions last for 30-35 seconds. Okay, and now she's saying I'm having a lot of pain. Now at that time, what will you do? She's now around 4 to 5 centimeters. What will you do? She's having a lot of pain with 4 centimeters. What will you do? Is epidural contraindicated?
No,
No,
it's not contraindicated.
Epidural is not
Epidural
contraindicated. You can
not
give an epidural anesthesia. Okay, then does not increase the chance of rupture uterus. What about oxytocin? Suppose you think contractions are not good, will you give her an oxytocin?
Yes, ma'am. Oxytocin can be given cautiously.
Very carefully.
Okay, you have selected the patient and now this patient is going. And what is the dosage of oxytocin you will start and how far you can give and when it should not exceed? Somebody has said already in the chat box. So it is a low dose oxytocin with 0.4 milliunits and you should not be exceeding 20 milliunits. Okay. We have to calculate everything. This is the oxytocin bundle approach protocol that has to be followed during this. For every labor you have to follow, and this should be followed strictly in previous cesarean section. Okay, and then
now patient has reached full dilatation. What will you do now,
madam? Before that, if she is crossing 4 centimeters, what will you do in this patient?
Autogram should be started.
Autogram should be plotted. So
yes, that's very important.
How will you? Autogram is plotted. And when will you identify this patient is going for an emergency cesarean section? When you are planning, when you will plan?
When it crosses the alert line for more than 2 hours itself, we can terminate the pregnancy. We can
now what patagram are you using now?
Ma'am,
what patagram is there now? What are you using? Are you using the alert line? WHO care
modified patagram.
So you have to only use the WHO care guide that is started in many places. I don't know about your center, but that is what is being done in everywhere. So you don't have the alert line in the action line in those patagrams. Okay. Yes.
Yeah. And when how you identify? Suppose it is a prolonged active phase. That itself is indication with the immediately you will check Brady, and then you will take the patient for emergency cesarean section. Okay. Yes. And now the patient has crossed, she has come to full dilatation.
What will you do now?
Going to do now?
It is a +2 station. What will you do now?
We should not ask the mother to push.
We can cut short the second stage by using
forces. It is a +2 station. So what will you do? +2 station. What will you do? Cut short. You will tell me what you will do to cut short.
Vacuum.
What will you do?
Forces.
Forces. See outlet forceps at which station you will apply?
+3 station.
I said +2.
So now +2.
Vacuum extraction.
Vacuum is better because if it's +2, you must use a low mid captive forceps. So the outlet forceps, the head should be crowning. Only then you can use the outlet forceps. So because the head is a little higher up, you can use a vacuum. Now the patient is delivered. Okay. Now will you do a vaginal examination? Plaster has also come out. Will you do a vaginal examination? What are the times of scar rupture? When not get scar rupture? As in intrapartum.
Okay.
During the
So,
active phase at about 5 to 6 centimeter of cervical dilatation, that time we can get scar rupture.
Okay.
And after the labor also, during the
that's very important. So
third or
scar
fourth
rupture can
stage
happen
also
during labor first stage, can happen during the delivery, during the second stage, and even immediately following delivery also. Though the percentage of scar rupture following delivery is only 8%, but the maximum incidence of scar rupture occurs in the first stage of labor. Okay. So now the patient is delivered. So you're not very sure whether the scar is ruptured or not. So how will you find out whether the scar is ruptured? The plaster has come out. How will you find out whether the scar is ruptured?
any excessive bleeding per
is
vagina,
there any
hematuria.
difference between the third stage management in a normal patient and this patient? Is there any difference?
No need of.
There is no need. The patient is taken like a normal patient. Amstel is given. Okay. Now everything is over. Immediately, what will you do?
How will you find out
There is
whether
no
she had a
bleeding.
scar rupture?
Bleeding per
Hemodynamical instability, hypotension,
maternal tachycardia, hypotension, hematuria, then excessive bleeding PV. That all should be.
So now my question is, will you do a
routinely,
vaginal examination?
Routinely, following delivery, will you do a vaginal examination?
Because that's the only way you can make out whether there's a hole in the rent in the scar. Will you do that?
No need to explore this.
No need. That is very, very important.
Because
There is
you
no
will
need. So you
again
have to,
accentuate. Okay, the
you
rupture.
have to only monitor the patient. How will you monitor the patient? You said pulse beep. Is there anything else that you can have in your labor ward to monitor the patient, which you can make out very early?
urine output, catheterization.
What else? Okay, what else? Anything else? Some equipment? Ultrasound isn't. Suppose you have an ultrasound, you'll be able to make out is there any free fluid. Even before the patient becomes hemodynamically unstable, you can just put a scan and see what all can you make out. If there's a rupture, what will happen? What all can tell you that there's a rupture?
Hemoperitoneum.
Okay, what else?
Yes.
Loss of integrity of uterus.
Okay, loss of integrity. Okay, how will you make out the loss of integrity? She's puerperal uterus. What else will tell you that the scar is ruptured? Any other finding? Loss of uterine contour. They said, what else? What is the other important that you'll find whenever there's a rupture? You've done so many cases.
What will you do?
You've done now. What will you see? What will you see when there's a rupture? What will it form? There's a bleeding. So what will happen?
Hematoma will be there, no?
You will have hemoperitoneum is one if there's obvious lesion. What else will be there? Madam has already told you. What hematoma is there? Where?
Broad ligament.
Broad ligament hematoma. So you can, if you do an ultrasound, you'll be able to make out a broad ligament. You might not have free fluid, but you might be having a broad ligament hematoma. Okay, so haven't you seen during a cesarean section, suppose the uterine vessels escape, you would end up having a broad ligament hematoma, isn't it? So when you do an ultrasound, you can just, after 1 hour, if you just put a probe on the abdomen and then you see a broad ligament, that means the patient's scar is given way. So that's an indication where you may have to, will you open up, suppose you identify a broad ligament hematoma, 6 centimeters. Patient's BP is 100 and 110. Okay, pulse rate is 120. In such a case, will you open up or not?
Yes, we will go for laparoscopy.
Yes, ma'am. We'll proceed.
Yes or no?
You want to do?
Yes, ma'am.
You must watch and see if the hematoma is increasing, then you are you going to evacuate with the hematoma?
No.
You should be very careful because once it's a big hematoma, sometimes it might injure the uterus also. So you should be watching carefully. Okay, so you must know whether to open or not open, depends upon the clinical situation. Okay. So
so to be individualized.
So for vaginal delivery, so when you have a vaginal delivery previous cesarean, so you must know what is the consent, then how we're going to monitor in labor, the use of oxytocin, the use of epidural, how we're going to do the second stage, and subsequently following delivery, how we're going to look for scar rupture, and how we're going to see for the severity of the patient. All these things you must see. Now this is as far as the VBAC is concerned. Now can we move
How
on
long
to...
you are going to keep the patient in labor ward under your strict care?
4 hours after delivery.
Is it 4 hours only? Suppose the patient goes to ward after 4 hours and bleeds there. Usually the book teaching is 6 hours.
Yes.
Okay. So this patient and also for abruption, all these cases will be kept for minimum period of 6 hours. Suppose you have a running labor ward, which cannot, somebody will be there in the post-operative ward to monitor the patient, or postnatal ward to monitor somebody should be there to monitor the patient for 24 hours, because anything can happen in the first 24 hours. So if the ward is full, then you are shifting only after 6 hours to be managed in the post-operative or postnatal ward for 24 hours under strict monitoring. Okay. Now,
Yes.
this
Now,
particular
suppose
patient,
you said you will design a cesarean section, and for your particular patient, you're going to repeat elective cesarean section. Okay.
Yes.
And how many weeks will you do?
39.
13 weeks. Okay, now tell me how you're going to do an elective cesarean section. How, when, what?
now she
What
is
is
a
the
previous
procedure?
LSCS. Previous LSCS.
Previous cesarean. Okay. Right from incision anesthesia, 13 weeks is crossed. What will you do?
We'll admit her and do complete blood count, renal function
See,
test.
everything is done. Everything is done. Your blood
But
is
every
blood
patient
bank
want
is
a renal.
ready.
Now I want, Deepika, I want this clarified. Why you saying renal, urea creatinine for everybody? Will you do for this patient, 27-year-old lady? Why you want urea creatinine? Is it necessary? Madam, is it necessary urea creatinine as routine?
The anesthetists are insisting, madam, nowadays.
Huh? Urea creatinine.
Anesthetist.
Yes.
Suppose he lands up with the renal shutdown or something like that, then they want the baseline.
Because that may not be the routine manipulation.
That cannot be the routine, but anything.
Anyway, in our centers, they're not asking. So, I mean, they should not, it depends, unless a patient has some problems. Okay, doesn't matter. It's not a routine, it's not part of the routine. Okay, yeah, now tell me. Now, when you get, now you're doing a repeat cesarean section. So, what are the problems that you anticipate when you take her up for a cesarean section? Because you have to get consent for that also. So, what are the problems that you anticipate?
Adhesions.
Adhesions, okay then.
Okay, then
Bladder injury, bowel injury.
Consent for sterilizations if mother is willing.
Okay, fine.
Okay. So now you tell me how we'll do the cesarean section.
What are the problems you anticipate? You said additions. So
Yes,
because of previous LSCS and additions, what can happen to this patient? How will what problem will happen to you when you open up the abdomen?
Due to adhesion, the bladder will be drawn up.
Yes.
And when we while we make the incision can directly go out to the bladder.
Okay. So the entry itself will be difficult.
Yes, ma'am.
You may not know where to go and put the incision on the. Okay. So that is difficult entry number one. It's like because of the additions. Then injury.
How will I enter the peritoneum? Is it bladder?
As high as possible.
You must always prevent an injury to the bladder. How will you prevent injury to the bladder? What are the various ways in which you prevent injury to the bladder?
Free of catheterization.
Catheterization is the first important thing. Every patient must be catheterized. Okay. Then when you open the
While opening the peritoneum, we have to
open as high as possible in the
bladder flap should be raised.
See,
and then you open as high as possible. And then what else will you do? You must palpate and see.
Yes, ma'am.
Suppose you are not able to see anything. Suppose
only
everything
if
is
it's thin, then that area only will make an incision, isn't it? Okay.
Yes,
and then so you open. Now you're seeing the lower uterus segment is densely adherent. Now you tell me how you make the incision. How you push the bladder down.
Sharp dissection, ma'am, in case of dense adhesions.
Sharp dissection.
Any other approach? Any other approach? Suppose it is thick at the center. Any other approach?
Where is it easy to enter to get a plane of cleavage? Which side?
Laterally.
Laterally, you can go laterally and then come to the center, isn't it? Okay. So if it's densely adherent, you don't try to push with the, especially with the sponge. It should be only sharp dissection. Okay. So you can lift up the bladder and then make a sharp dissection because inadvertently you can even injure the bladder. Okay. Okay. Now you make the incision and then how will you stretch the incision?
While manually.
Transversely, we have to stretch the peritoneum.
Okay. Peritoneum
Incision. Incision, ma'am. Incision
into
should
the lower
be
uterus.
stretched transversely.
Okay. Okay, now you've
Why
delivered
it
the
should be
baby.
stretched? Why it should be stretched? Why not sharp dissection with scissors on the lower uterine segment?
Bleeding will be more if
Sharp dissection.
is cut.
So, okay, fine.
Okay, now you've delivered the baby. Okay.
Yes.
Now tell me how you suture.
What are the difficulties you will have in this 39 weeks gestation? You said the head is mobile. In your examination, you said head is mobile.
Yes,
Isn't it? So, what problem you will have in delivering the head?
Mobile head will be difficult
Easily
to
slip off from the hand, ma'am. So we
Yes.
should ask our assistant
to give lateral and fundal pressure can be given by the assistant.
Pressure, number one.
Then
Second,
rupture of membranes should be done and liquor should be drained out so that the fetal head will
moves
come down to the incision.
yes.
And then head can be delivered by flexion. If
it is not possible, we can go
use
for
forceps.
Okay, forceps are
What is easier? Anything else you can use forceps or you can also
Vacuum.
use
Vacuum can
you
also
use,
be
isn't it?
used.
Okay, so bring the head to the incision and then you can deliver. Now the same thing, suppose the head is deeply engaged. What will you do?
In deeply engaged
Because
head,
it's 39 plus 5 days, 38 plus 5 days. She's got into labor, you've not realized. What will you do?
we
What will
can
you do?
ask the assistant to push from below to release the vacuum. If it otherwise, we can go for Padvartan technique, ma'am.
You can go for either push from above or pull from push from
Padvartana
below or
model.
pull from above. So you can push, that is one technique, or you can do a Padvartana, that is actually easier because the chance of any injury is less. When you put your hand inside and then try to push push from below and then try to deliver, there are more chances that the wound can get extended. You can do Padvartana if you've been trained with that. So what are the other things that is coming up now? In Western countries, there are so many other techniques that they're following for a head which is deeply engaged. Oh, they use a fetal pillow, isn't it? Have you not heard? Fetal pillow. So they use a fetal pillow, then they can fill up the bladder, the head will go up, and then all these things can be done. But the two methods which are acceptable is your Padvartana technique and the push. That's to be okay. So now, so in difficult situations, you must know how to deliver the head. Okay. So now, in the case of previous cesarean, when you suture, when after delivery, how will the upper segment and the lower segment look like? Most often.
Upper segment will be
contracted, thick, and lower
segment will be thin.
Very thin, isn't it? So you must be able to approximate correctly because the upper segment is very thick and the lower segment will be quite thin in some cases. So correct approximation is very important. Okay. Now after delivery, will you do something? What will advise patient? Will you do something?
Spontaneous expulsion of placenta. Spontaneous delivery of placenta. You can wait for spontaneous delivery.
Okay.
Okay.
Okay, you wait for problem. And then what else?
Meanwhile, we have to secure the angle.
Secure the angle, okay. And then?
Check for the bleeders.
Will you suture a single layer, double layer? What material?
Double layer 10 Vicryl is used.
Okay. Now, in the case of previous I want to do a sterilization. Will you do single layer or double layer?
If we go for sterilization, then a single layer closure is enough, ma'am. If sterilization is not done, then we can go for double layer closure.
Double layer. How to do the suturing?
We should not take the endometrium.
No.
Both.
What I am saying, whether it should be whether
no
it is
need
a
of locking the
or
sutures.
running suture.
Running sutures is enough.
Okay, what is the tensile strength of your Vicryl 10? How long does it take?
90 days.
30 days. It is not 30 days. Okay. Catgut? Okay. No, it is 7
to 10 days it will absorb.
7 to 10 days. Okay.
Is there any study which is better? The two is Vicryl better or is catgut better?
Vicryl is better, ma'am, because in chromic catgut the chance of infection is high.
Is there any study recently comparing both. What is it most? You must know two important studies as far as cesarean section is concerned. What is the study which says about the use of, which was studied between mitral and the chromic catgut? What is the study? Huh? Don't know? Anybody in the audience? What is the study which is used? Which is compared mitral and chromic catgut? Huh? Coronal study. There are two studies. One is a cesarean study, Caesar study, and the other one is a coronal study. So this coronal study has these things you must know. It has studied three things. One is the use of mitral versus chromic, and they said both are equally effective.
Yes, ma'am.
So there's no difference in many countries, in the French, etc. They only use a chromic catgut. Whereas in our part of the country, I think most of us use only mitral. We've done a systematic study and said that both the both mitral and this is the same thing. So what are the other three things which has been done in coronal study? The one is they have done the exteriorization of the uterus. After you delivered, you exteriorize the uterus. Some people put the uterus inside and suture. So they said again there is no difference between exteriorization and suturing the uterus inside. Okay. The third part that they have done is what? What is the third thing? Blunt. What is the third thing? Oh. Blunt dissection versus sharp. Okay. So
Okay, when do you
both are the same.
Okay, when do you exteriorize the uterus? When you are doing the section, when will you exteriorize the uterus?
After the delivery of the placenta. After the delivery of the placenta.
Oh. At which, why you want to exteriorize the uterus?
For visualization of the posterior surface of the uterus.
And to
If
look
there
for
is
any
any
adnexa
hematoma.
pathology. And
For
it is
clear
easy
visualization
to
of bilateral
suture.
adnexa also we can exteriorize the uterus.
And you said the patient is in labor and you are taking up the patient in the first stage. Which stage is better, second stage or first stage?
First
stage is better.
Okay, why? Why not the second stage?
Second stage, bundle string maybe.
Yes.
Updrawn blood. Updrawn bladder.
Second stage, what will happen? The cervix is fully dilated. That is low down. Okay.
Second stage, lower uterine segment is thinned out.
Lower segment will be thinned out. More chance of
So
extension.
where will you put the incision? Where will you put the incision in the second stage and where will you put the incision in the first stage of labor?
First stage in lower uterine segment we can do the incision, ma'am.
Yes.
In second stage, lower uterine segment is thinned out, so we can put the incision higher above the lower uterine segment.
Little higher.
Now, second stage, suppose you put the incision very low down, what will happen?
Chance of bladder rupture and
bladder, if you push the bladder, there will put the incision.
Anything else.
So you push the bladder,
entry into the
bladder. You are seeing the stretch out lower segment. Is you're making the incision high up, you're putting the incision low down. So what will happen? So now I'm saying, where will your incision be? When you put a
into cervix or
make the incision low down, what all? You might put the incision on the cervix, or sometimes the incision will be in the vagina also. Because lower segment has stretched so much. So always you must make a precaution when you do a cesarean section for the second stage, always make it higher. You don't think lower segment is nice. You see, let me go low down and 40. You go low down, you'll be in the vagina. Okay, so incision will not be in the uterus, it will be in the vagina. So you should be very careful. So make the incision little higher. Okay.
Higher.
You identify with lower uterine segment.
Loose fold of UV peritoneum.
UV peritoneum, and that is where you have to make the incision. Okay. So, madam was asking where will you exteriorize? So whenever you were not able to see the lower plug properly, or if there's excessive bleeding, then you will do the exteriorization. Okay. Now, along she's had 2 previous cesareans now. She's conceived immediately. So what will you counsel the patient for?
Regarding sterilization.
Regarding sterilization,
the patient wants sterilization, fine. And the pediatrician accepts. He says everything is fine. Otherwise, too short intervals.
Double closure of uterine.
No, what else will you tell her? If you leave her, she will. The baby is very small to do a sterilization. So what else? You can put a
copper PPI.
Copper is in it. You can insert a copper T and so
Intracesarean property, you can do it. Okay. And when will you ask, how will you follow the patient later? This particular patient, if you insert property, what will be the advice?
You have to ask
at
to
discharge?
come to OPD to check the position of copper-T thread.
Yes.
Like
How long you will be
6 weeks,
following up?
up to 6
year.
weeks. And once in every 3 months till 1 year.
You want to do once in 3 months? He won't be coming.
6 weeks, 6 months, and 1 year.
Yes. After 1 year, what at 6 months, when you see the patient, what is the advice you are going to give her? Now the baby is fine.
Interval sterilization. We can advise her for interval sterilization.
Which approach of sterilization will be good?
Laparoscopic sterilization.
Okay. Yes.
Now, can somebody tell me about the Caesar study from the audience? Anybody can tell me about the Caesar study? There are 3 points. 3 points for Caesar study and 3 points for Corona study. So for Caesar study, anybody at least 1 point at least. All of you are final years, no? Huh? So that study only compared single closure following double closure. Whereas Corona study used material.
Like material.
Whether it was mitral versus chromic. So here in Caesar study, they studied single layer versus a double layer closure. And then they said pelvic peritoneum closure versus no closure. And the third one was use of drains and no drains. So these are the 3 things which is there in Caesar study. And they found that none of everything is the same. Whether you did single or double closure, there was not much of difference. Whether you close the peritoneum, they found that when you did not close the peritoneum, the cesarean rate, the time taken was much faster. The pain was much less than for these patients. And routine drain is not advised unless the subcutaneous fat is more than 2 centimeters. Okay. So now this is as far as the cesarean is concerned. Let us see some cesarean section in certain special indications. Now tell me about the antibiotic. What antibiotic will you give? You said you will give antibiotics, no? What antibiotics will you give and when will you give the antibiotic?
First generation cephalosporin is
and when will you give that
60 minutes before the skin incision. 60 minutes before the skin incision.
Now, suppose the patient is obese, she is 100 kg. Then what is the dose?
Anything else also you want to do for this obese patient?
Post-op thromboprophylaxis should be given to this patient in early ambulation.
Early ambulation. Adequate hydration should be done. Early catheter removal.
If you want to what is the dose? Will you give the same 1 gram? So say give 2 grams. Sometimes they say you can even go up to 3 grams of cefazolin. How many doses will you give more antibiotic?
Single dose.
Post of
1 dose. But when will you give the second dose?
Post up after 1 hour.
1 hour. If the surgery is taken more than
3 hours.
For more than 3 hours, then you can repeat the dose after 6 hours. Because generally 2 doses is enough. That is said to reduce the SSI. Okay. Now, suppose the patient is obese, where will you make the incision? She has a big, so much of panels is there. Where will you make the incision such patients?
Joel, low vertical.
So low vertical also, there are some studies which says you can do a subumbilical incision done. Okay. But there are various hooks by which you can lift up the abdominal fat and then you can still go to the abdomen and then make the incision. Okay, that also is there. What else have we done? So you must know how to deliver the head, difficulties in delivering the head. Now in your particular patient,
suppose you are doing an elective cesarean section. Your baby, handing over the baby. What are all the complications that are expected at that time?
Transient tachypnea of newborn.
Yes. Yes. Anything else?
Yes.
Later, the baby can develop atopy, asthma, allergic.
Complications. More than that,
Yes,
you have
okay.
taken everything, you have done everything. Sometimes prematurity can be there, no? At times you cannot predict. So for that, for preventing that, what will you do?
Steroids will be given.
Antenatal.
For posting for elective section, we have to confirm the gestation age.
With dating scan.
Sometimes it is with all that these patients will go in for these babies may have prematurity. We cannot be 100% foolproof.
Antenatal corticosteroids is always administered, ma'am, before elective
Suppose you do-
cesarean section.
Now,
Suppose
you said
you
your
do
patient is 38
emergency.
weeks and 5 days. Will you do? So will you give steroids? What is the indication for steroids? When will you give steroids? Suppose you're doing a cesarean 39 weeks. Will you do?
According to RCOG guidelines, we can give steroids up to 39 weeks. Of,
Only up to 30. Suppose you cross certain weeks and then you do your cesarean section.
It's
there is
not
no
necessary.
need. How many doses will you give? Steroids.
Four doses of injection dexamethasone, 6 milligram.
The dose is
For
same
lorazepam.
for artists. Whether you're doing dexa or beta, you can give the same thing. That they say dexa is better than the beta. Now, can you tell me how you do this cesarean section? What incision will you make? Primary cesarean section. How will you do from skin? What incision are you doing? How will you
Joint
do?
coil.
What is a joint coil?
Incision.
What is a skin incision? How will
It
you
is
do
a suprapubic transverse incision made 3 centimeter below the imaginary line between the two anterior superior iliac spine.
You are talking about Joel Cohen?
Ma'am?
Joint coil.
How will you do? That is what you are doing.
Yes,
in your hospital, is that the method you're doing?
Joel, yes, ma'am.
Okay, tell me how you do.
Incision is deepened and
what is the length of the incision? What should be the length of the incision?
Up to 15 centimeter we can make. 15 centimeter.
Okay, it should be at least 12 centimeters, 10 to 12 centimeters. The size of the alice was roughly. Okay, yes, it should be big enough to another feet have to be extracted. So don't make a incision less than 10 centimeters. Definitely not. Okay, 12. Okay, 10 to 12 is what is advised. Okay, then
separate the subcutaneous tissue and then rectus sheath.
Blunt
dissection of the subcutaneous tissue. And then
rectus sheath is
incised and then separate the rectus muscle. And we will enter the peritoneum. Again, blunt dissection of the peritoneum. Open the peritoneum.
How will you separate the rectus sheath from the rectus muscle? Is it
cranial
like this or like this? How will you do? How will you do the stretching? Transversely or up and down?
Transversely.
Cephalocaudal or is it laterally?
Rectus muscle is separated transversely.
How will you separate the rectus muscle from the rectus sheath? How is it done? It should be you must stretch it up. Your hand should not go laterally with this, up and down. Okay, cephalocaudal should be the way in which you separate the rectus sheath from the rectus muscle. Okay, and then you enter the peroneal cavity. So that is also again
by blunt dissection.
By blunt dissection. Okay.
Dextro rotation should be corrected before.
That is very. How will you know that there is dextro rotation?
You have to insert the hand inside.
How will you know? Okay, insert the hand, but
round by seeing the round ligament of the left side of the.
So when you see the round ligament which is pointing anteriorly in the midline, then you know that there is dextro rotation. So you immediately correct the dextro. You don't correct, what will happen? Suppose without correcting, you're making incision. What will happen?
Incision will be extended to the left side and the uterine vessels will be damaged.
It means your vessels will be damaged. So always make it a routine to put a hand in the sea with this cutter, or at least you can see where the round vessel. They should be inside the laterally, not in the center. Okay, then you identify the lower uterine segment. How will you make the incision in the lower segment?
UV fold of peritoneum should be dissected and the bladder should be pushed down. And then lower segment incision should be made. Curved incision.
Facing up.
Okay.
And with 2 fingers.
You've done a cesarean section, here the lower segment is very thin. You're not able to, with your incision, you're not able to deliver the baby. Now what will you do?
Open banana.
What will you do now?
Higher up, incision can be made higher up.
What do you call that incision as? The incision can be made higher up means where? No, you open. Okay, but the baby is not coming out. Okay, the incision becomes
After
very
opening, we can
small.
extend to J shape or T shape can be done.
You can make a J-shaped incision or you can make a T. What is a T-shaped incision? What is a T-shaped incision? What is a T-shaped incision?
Inverted
Is it T or inverted T?
Inverted T shape.
So, okay. Now, suppose you
Suppose you do
an
an inverted T incision. What will you tell the patient, or which are the time of discharge? What will you see in the discharge summary? And how will you advise the patient?
Documentation of the type of incision should be done in the discharge summary.
Yes.
That's very, very important, isn't it?
Because the
And
chance
not
of
only that,
rupture is high
In the future.
upcoming.
and what else you will tell the patient? You cannot tell the patient you have gone into
Have
a
to-
complication at that time. So what advice?
Mother
will
should
you
be
give at the
advised
time
for
of,
elective cesarean section in next pregnancy, ma'am. We
yes,
can't.
she should get admitted for an elective repeat. Okay. She cannot come for ask for a TOLAC. You also should not encourage anything. You should strictly tell her she should get admitted at 38 weeks for repeat.
Elective.
Now, a case of previous cesarean has come to you at 8 weeks of pregnancy. Okay. And then there is something when you do a scan, which says the pregnancy is lower down. So, how will you differentiate? Is it a cervical pregnancy or is it a cesarean scar pregnancy?
Ma'am, the gestational sac get embedded in the scar. Myometrial thinning will be present in scar ectopic pregnancy. And negative sliding sign in USG is a feature suggestive of scar ectopic.
Okay.
Abnormal vascularity over the scar side will also present.
And the gestation sac will be pointing anteriorly. Okay, so all these things will be there. Now, is there any way to, what is the niche? Suppose you've seen her before pregnancy, and then there's a niche. What is that niche?
Disruption in the scar.
What is it? Disruption in the
scar, previous scar.
The scar. Disruption in the scar. Is there any way in which you can measure the niche and tell the prognosis?
3D
So you must see the distance from the niche apex to the myometrium. That divided by the total length of the myometrium. If the percentage is less than 50%, then the prognosis is bad. So the niche you have from the niche to the myometrium and the entire myometrium. So you divide if the score is less than 50%, it has a bad prognosis. So you can do it even before the pregnancy. Now, suppose you've seen a scar pregnancy the next time at 8 weeks. Now, what will you tell the patient? What will you do? How will you manage a scar pregnancy?
We have to advise for admission of the patient, ma'am.
How will you manage a scar pregnancy? Cesarean scar pregnancy.
Laparoscopic scar ectopic excision can be done.
Yes.
Anything else?
Eticides can.
Anything else? Can you do suction evacuation?
Yes, ma'am. Can be done.
You can do suction evacuation also. So you can do histoscopic suction evacuation. You can ordinarily do suction evacuation. There are many methods. Different approaches are there. Okay. Yes. Methotrexate. Yeah, you can also give methotrexate also. Methotrexate, then follow it up. Okay. Then, because earlier on we were thinking that if it's scar ectopic, it's a major catastrophe. But now, with many cases of scar ectopic, we've become a little older and we're even doing a suction evacuation. You can also do a uterine artery embolization if you think that the vasculature is very much and she's going to bleed profusely. Uterine artery embolization also can be done prior to evacuation. Okay, now the next dreaded complication following a cesarean section is what?
Placenta,
what is it?
placenta previa and placenta accreta syndromes.
Dreaded is placenta accreta.
Accreta syndromes.
Placenta previa is not
Spectrum.
Placenta accreta spectrum.
Okay, suppose she comes at 24 weeks and then it says adherent placenta. Okay, PAS. Okay, well now how will you manage the patient?
We have to plan for elective cesarean with in situ hysterectomy, ma'am, in case of.
When? How many weeks?
35 to 36 weeks.
Okay, so MRI, see somebody's asked, will MRI should be done or not?
In case of posterior placenta previa, MRI can be done. And
because ultrasound itself is a Gold standard.
Confirm
It's not
Very good.
necessary that you have to do an MRI. But if you have a doubt, especially posterior placenta, then you can do an MRI. But otherwise, for all patients, it's not necessary. Only if you have a doubt, it's not very clear, then you can do. Otherwise, it's not indicated because ultrasound is by itself very, very informative. Okay. Now, when will plan for a cesarean section, and will you keep the patient in the hospital or what? And what are the problems of a morbidly attended placenta?
Patient has to be admitted, ma'am, in the hospital, and
Yes.
will terminate by 34 to 35 weeks of gestation. Adequate blood and blood products should be available while taking for procedure. And she should be informed about the risk of hysterectomy and massive transfusion.
Yes.
Bladder injury during the
Bladder
time of
injury.
procedure.
Multi-organ.
Okay, and so all that is very, very important. So how will you do the cesarean for such case?
She should be planned elective section in the morning hours
Senior
when the
obstetrician
senior
should be available.
obstetrician and other multi.
Where will you make the incision? How will you deliver the blood? Where will
incision.
you make the incision?
Plus, lower uterine segment incision
In
can
such
be.
case, only having an ultrasound in the labor in the theater is very, very useful. So you make the incision above the
Localization of placental margin.
Will you do classical or will you do transfundal or will you do lower transverse? Whatever this will you do.
Transverse incision itself can be.
Why? The placenta is accreted, is
You are
lower when
now
you make
going to
transverse
maybe
incision.
you.
Because most often it will be a placenta previa which has become a placenta accreta most often. Because placenta in the lower segment. So if you make a transverse incision, it's going to be very difficult. So where will you make the incision mostly?
Classical.
It
You
is
can
Upper
plan
segment.
a classical, but some people say you can also make a transfundal incision also.
Incision.
Okay. Okay. And then you deliver the baby. If you, then what else would you do after that?
Placenta should be
Accurate.
leaved in situ.
No manual removal should be tried, ma'am. You can proceed with
Hysterectomy.
Hysterectomy. And who will you have when you're doing a cesarean hysterectomy? Who else should be there in this case of placenta?
Urologist.
Accreta. You should have a urologist because
Urologist.
chances of
Invasion
hysterectomy
into
is
the
very,
bladder.
very high, isn't it? Because when you push the bladder, it will be very difficult. So you should have a person. Now, how will you intervention day? How will you prevent the PPH in such cases?
Placental bed suturing. To avoid placental bed suturing, we can apply mop for 4 to 5 minutes, and Cho sutures can be done over the placental side.
Where? No, which is a case of placenta accreta. You're not going to touch the placenta. No.
We are not going to
So-
take off the placenta.
So how will you, the bleeding, how will you arrest the bleeding?
Uterine stepwise devascularization.
So before touching the placenta, there are many ways in which you can reduce the bleeding. So you can do separate devascularization, you can do an internal artery ligation, or if you have facilities, you can do an uterine artery, you can place the catheters. You can't, you won't do the embolization before delivery. You can put the catheters and then you can do the embolization later. Or you can put the aortic clamp. Okay, there are many ways. All these are some ways in which you can reduce the bleeding. Okay, and we must definitely have massive blood transfusion and do the hysterectomy as fast as possible. We do subtotal or we do total?
It is an atonic PPH.
We will go for total
Placenta
hysterectomy.
previa and placenta accreta, we'll do subtotal or total?
Total hysterectomy.
Total hysterectomy will remove the entire placenta, isn't it? So it's
Yes,
a
ma'am.
total hysterectomy which is being which you should do, especially if the placenta is lowered down. What is the triple P procedure?
Pre-operative localization of the placenta should be done for incision. Then
Pelvic
pelvic
devascularization.
devascularization and placental non-separation, and we proceed with myometrial excision.
And resuture.
Resuture.
So we have not done. I mean, that is a thing which is coming up. Okay. So when you do this for placenta accreta, when you push on the bladder, the chance of, because the myometrium is so thinned out, the chance of bladder injury is very, very high. Suppose they have difficulty in opening, in pushing the bladder, what can you do? You can deliberately do a cystotomy. You call the urologist, the person they do is they cut open the bladder. So this is deliberate. Instead of doing a ragged incision, you can deliberately do the incision and then you can see. Okay. And then you have to put the catheter for long term. So all those things. Is there anything else that we've left out, madam, in cesarean?
I think we covered.
Covered everything, you know, placenta. What are the complex post-operative management? How will you manage a case following cesarean section? What all will you manage post-operatively? When will you start on IV fluids? How will you monitor the patient? What are the complications
Vitals
can
not-
happen post-operatively?
For every 15 minutes in the first hour of post-operative period, and every half an hour in
Next,
second hours, and in every 1 hour in the next 4 hours. And
What will you see? What
BP,
will you
pulse
see?
rate, uterine tone, temperature,
vaginal bleeding.
urine
Temperature,
output.
that time is if you have temperature. Every 15 minutes you're going to see the temperature. Huh?
No, ma'am.
Then why you want to tell lies like this?
Pulse only. Pulse and
Pulse and BP will see, but
Pulse,
temperature you
BP,
won't.
urine output, uterine tone and vaginal bleeding we will see.
How you not to know? You must do realistically. Okay.
Yes,
Yes.
So you will definitely see half-hourly pulse. That's enough if you see half-hourly pulse. Okay, pulse, BP. You must see the height of the uterus, what is the tone of the uterus, and you will see the urine output. Supposing you get a call saying no urine output for 4 hours following delivery. What will you do?
Can be due to acute retention followed by spinal.
Why you
Can it be
retention?
anything
You
else?
put the
Can it
catheter,
be
no?
anything else? You put the catheter.
Hypovolemia.
No, before
first-
that one.
Yes. So it might be a hypovolemia is one thing. Okay. The other one is
We will check for the tubes.
tube might be kinked or there might be a block. So the first thing you will check. But before that,
For the
about
clot.
4-6 hours, suppose the patient is not a drop of urine has come. Will you see anything? Will you look for something?
Uterine
You definitely
tone
see a
and
pulse,
bleeding
but will you
PV.
see anything else?
Then
What?
condition of the patient.
Abdomen distension.
Abdomen distension. So bladder. Bladder distension.
Yes.
So bladder distension with the catheter block. Then
Bladder injury or
if you see catheter block, you will check. Then you will see for the bladder distension, nothing is there. Then you want to do something for the hypovolemia.
fluids, adequate
Rushing.
hydration.
Rushing of the fluids. Yeah.
Still the urine is not coming. Is there any drug?
IV Lasix. We can.
The BP is stable. We can.
Yes. Anything else?
Ultrasound to rule out bladder.
Hemoperitoneum. To rule out hemoperitoneum, we will see for ultrasound.
Usually that doesn't happen. You'll give Lasix and we'll see by the time the patient will pass urine. Okay.
Yes.
What else? Have we covered everything? Anything else we have missed? Anything else?
Minal Kodi and Chitra, congratulations. You have finished 50% of the obstetrics book. Thoroughly
ma'am.
analyzed.
Thank you.
Thoroughly analyzed. Okay. Well done. Okay.
Thank you, ma'am. Thank
And
you.
the students are really blessed. Chitra?
Thank you, ma'am.
Thank you.
Right. Now, Chitra?
Not here.
Chitra is not there.
Yeah. She's not
Chitra?
here.
Ma'am, I'm Sundaravani, ma'am. Thank you, Miralkut, ma'am.
Thank you.
Thank you, ma'am.
Yeah,
Thank you, ma'am.
Kanyakumari.
Right,
Ma'am,
right.
yes, ma'am.
Where are you,
Thank
Sundaravani?
you,
Where
ma'am.
are you?
I'm happy to share with this stage, ma'am.
Madam,
Okay.
please switch on your
Madam,
video,
she was
madam.
my PG.
Madam.
She was my PG
Minal,
in
ma'am.
2007.